Hi, welcome. I'm Dr. Tony Malioco, the Cancer Informant. Welcome to our podcast. This is our second podcast in a series that we have dedicated to cancer patients. I'm your host, and I'll be talking about my insights into cancer pathology and cancer diagnosis and treatment. Today, we're going to focus on the beginning part of the journey, when a patient first learns that they have cancer. We're going to review how this diagnosis occurs and what happens to the tissue specimens that are removed from a patient, what a pathologist is and what roles they play, and really the importance of all of these activities. A cancer patient may present in a variety of different ways. They may come, for example, with a lump. They may have undergone a screening procedure, for example, a colonoscopic examination, or maybe a mammogram where there's an alteration in the breast tissue. Sometimes a cancer may present more dramatically. A patient may present with a seizure where they may collapse, or a pathologic fracture that causes a bone to break. So the first thing that happens is that on a screening examination, that a patient, for example, goes for a mammographic evaluation. The radiologist will read the X-ray and make an assessment. The radiologist may determine there's an area of abnormality in the breast, which requires further investigation. This may involve additional radiological imaging, for example, sonograms or MRI imaging of the breast. And then ultimately a biopsy is done. The biopsy could be done by the radiologist or perhaps by a surgeon, and a piece of tissue is removed. It could be a tiny piece of tissue using something like a fine needle aspiration where cells are really sucked out and put into a bottle or smeared on a slide, or it could be a larger removal where the skin is cut and a piece of tissue is excised. What happens to this tissue? Well, typically the tissue will be transported to a pathology lab. So if the procedure has occurred in the hospital, the tissue may be transported by a porter in a fresh state, meaning that it's directly removed from the patient and then carried to the lab for evaluation. If the lab is at a long distance away from where the procedure occurs, the specimen may be placed into formalin. Formalin is a special kind of chemical that preserves tissue. The way it works is that tissue is placed into the formalin dissolves into the tissue or permeates the tissue, and it causes the proteins in the tissue to become cross-linked and decomposition to stop. So it essentially preserves tissue, which allows it to be evaluated and examined later. Tissue can stay in formalin for a long period of time, anywhere from 24, 72 hours, or even much longer than that. Ideally, the time in formalin would be less than 72 hours. This is for optimal. It's also important that the amount of formalin be adequate for the specimen, or it may result in improper fixation and actually loss of the specimen. So management of the specimen is very important. Now, when the specimen arrives at the path lab, the first thing that happens is the lab needs to determine, has the specimen be labeled correctly? Is it actually from a correct patient? And this is really important because it might surprise you to know that errors can occur, that if specimens get mixed up or the numbers get smudged, this could cause obviously a very severe problem down the road, that if we mix up a benign tumor biopsy from something that's malignant, this would result in a very critical error in the subsequent diagnosis. So it's very critical that the lab take high care in managing specimens that come in. This also raises a discussion about what is a pathology lab. And a pathology lab is a very important center that provides diagnostic services. So pathology labs are directed by medical doctors normally, a laboratory expert, for example, a pathologist who will be overseeing the medical functions of the lab. They will also have administrators that will ensure that the lab is operating according to proper regulatory. And then there'll be many staff members that populate the lab that have various jobs in terms of receiving specimens and entering data into the information systems and then processing the specimen. So once the specimen comes into the lab and it's cleared that it is the correct specimen, a pathologist will examine the specimen. In some cases, if it's from a breast, for the purpose of evaluating calcifications that are abnormal, the lab may actually X-ray the specimen to document that the abnormal calcifications have been excised and that they are present in the specimen. So the pathologist will examine the specimen and really cut it into tiny pieces. These pieces will be placed into basically small plastic baskets or boats, which then go for further processing. The examination of the tissue is quite important. If a large specimen is sent to the lab, for example, a mastectomy specimen, the pathologist must look at this very carefully to determine, is there a tumor inside of the specimen? He or she must measure how big is the tumor, what is the diameter of the tumor, how close is it to a margin. It's very critical to the surgeon and also to the patient to know, has a cancer been completely excised? And also the size of the cancer. This information about the size of the cancer and the completeness of excision is very important for planning further treatment. The size of the cancer is involved in staging a cancer. So stage tells us how far advanced a cancer is. So cancers of higher stage, for example, stage 2 or 3, are cancers that have progressed to a more extensive involvement of the patient. And these cancers are harder to treat. So they often require more aggressive therapy and potentially systemic therapy. If the cancer is localized and small, often these cancers are curable simply by cutting them out by surgical excision. And this is where the pathologist's examination is so important, that the pathologist really must determine, has the cancer been completely excised, and is there any chance that some of the cancer has been left behind in the patient? If cancer has been left behind, then additional surgery might be necessary, or residual cancer can actually be treated with special kinds of therapies such as focused radiation oncology and radiotherapies. So this step is actually very important. In addition, there may be additional tissue that's sent into the lab. These may be lymph nodes. Lymph nodes are very important in the assessment of cancer stage. So a pathologist will look at a piece of fatty tissue and determine, are there any lymph nodes present in the tissue? The pathologist will isolate those nodes and count them, and then they will place them into the boats for further processing and later examination down the microscope. So the recovery and proper assessment of lymph nodes is also extremely critical. In certain cancers, for example, colon cancer, if there are less than 12 lymph nodes identified, the case is considered inadequately staged, and that there's inadequate information to actually determine the optimal extent of the disease and what sort of therapy should be utilized. We can see that the lack of lymph nodes could be essentially blamed on two different specialists. One, the surgeon may not have removed the lymph nodes, or secondly, a pathologist may not have actually spent enough time to carefully identify them and remove them for examination. But the lymph nodes are of very great importance in terms of assessing the stage of the patient. Sometimes a procedure called a sentinel lymph node biopsy is also done. This is where a special lymph node has been identified as being the most important lymph node. And this is done where the surgeon will inject material into the tumor, for example, a colored dye or radiation marker, and then the axilla is examined to find the colored lymph node or the lymph node that's radioactive for excision. We believe that this lymph node is the most important one, as it would be the one that would be most likely to contain metastatic disease. The pathologist would examine this lymph node, and if the lymph node did contain metastatic disease, additional lymph nodes would then be removed. If the lymph node was negative, then additional lymph nodes would not be removed. It's important that the amount of lymph nodes being removed is actually minimized because the removal of lymph nodes can cause problems. It can interfere with nerve functions and can also cause a condition called lymphedema, where there's swelling of the arm. And this can be really problematic in women with breast cancer. So this step is a very key step, the initial examination of the tissue and the selection of material for microscopic examination. And overall, this is called the gross examination, and it's really the first step that happens in a pathology lab. Sometimes a pathologist will do this step themselves, or they'll assign this duty to a trainee, perhaps a resident or fellow. There are also very specialty trained assistants called pathology assistants that can also take on this task to examine tissue and do the initial inspection and selection of the sub-tissues that will go on for microscopic processing. Now, moving on to microscopic processing, the little pieces of tissue that have been excised are then placed into something called a tissue processor, and usually this occurs overnight. So what happens in there is that the tissues are exposed to a series of chemicals. Actually, ethanol is the main chemical that they're exposed to, and they're placed in a series of ethanol solutions that have an increased concentration of ethanol. So it will start at 95% ethanol, and then it will go up to 100% ethanol or 99% ethanol. The purpose of this is to remove all of the water from a specimen, replace it with ethanol, and convert it into an organic phase. Then at the end, the specimen is put into xylene, and then that specimen has all of the water removed from it. This is an important step, the dehydration of the specimen. Now, at the completion of this, which usually happens the next morning, the completely processed specimen is now embedded. And what this means is that the piece of tissue is put into a paraffin embedded block, and paraffin wax, warm wax, is placed onto the specimen, and it's molded into a cuboid piece of paraffin wax that contains the fixed piece of tissue. This is an important step, and this is the paraffin embedded block, or the creation of the paraffin embedded block. And you might hear about this. They call it FFPE material, or formalin fixed paraffin embedded material. And when the cancer tissue gets to this stage, it is extremely stable. So a piece of cancer can stay in a paraffin embedded block for years, even decades. And we can go, those paraffin embedded blocks are stored for a patient for at least 10 years, and they can be stored for much longer. Academic medical centers may keep tissue for 20, 30, even 100 years. And it may surprise you to know that we can go back to those very old pieces of paraffin embedded material and still examine them. They maintain the morphology, and they actually contain important biomolecules inside of them. For example, DNA and protein that can be evaluated. Paraffin embedded material is stored at room temperature. Now, what happens on the next step? So this is day 2 of the specimen. Once the specimen is in the paraffin embedded block, it then goes for microtome slicing. And in the microtome slicing, a technologist will cut very thin slices of this paraffin embedded block and place it on a glass slide. These are 5 micron thick, or about the diameter of a human hair. These go onto a glass slide, and they're air dried on that slide. Once this has been completed, a glass slide is made from every paraffin block from the tissue. So if a patient has a small piece of tissue, there might only be 1 block. But if the patient has a very large amount of surgery, for example, if they had a colectomy and a spleen removed or other organs, there might actually be hundreds of blocks that are created from the specimens and are now available for evaluation by the pathologist. So these blocks are all cut into thin slices and then put on a slide, and then typically they're stained. The standard stain that is done on every pathology specimen is something called an H&E stain, or hematoxylin and eosin stain. This stain gives color to the tissue, so that it stains it pink and blue, so that when a pathologist looks down the microscope, they can actually see the cells and see what sort of tissue it is. So after the staining, the slides are mounted and then delivered to the pathologist's office. All of this happens very early in the morning. So typically the histology staff will come in very early, maybe 4 a.m., start the embedding and cutting all the slides very early in the morning. And then the slides are now available for the pathologist to review. So the pathologist will start reviewing their cases. They will go through the slides and they will look at the slides and determine what's present in the slide. Not every case is a cancer, so sometimes a pathologist will have a skin biopsy for an inflammatory condition, and pathologist might examine it and say this is a fungal infection. When the case is a cancer, the pathologist will examine the slides and determine, is there cancer present in the slide? They'll determine what kind of cancer is it. So a pathologist will classify the cancer. There's many different kinds of cancer. For example, if we take breast cancer, there can be lobular cancer of the breast, there can be ductal carcinoma of the breast, other types of carcinomas of the breast, sarcoma, etc. So the pathologist will examine the tissue carefully and make that diagnosis. Pathologist will also grade the tumor. So this is a grading system where they will look and say, is this a low-grade tumor? Meaning that it's biologically much like the tissue it's arising in, that it's not, it may be forming glands if it's in the breast, the nuclei are small and round and it's not dividing very quickly. These are signs that this cancer is growing slowly and may be less likely to metastasize. So having a low-grade cancer is very helpful to know. Pathologists will also measure the size of the cancer and determine if there are other features that are problematic, the mitotic rate, if there's invasion of blood vessels, and if the margins are involved. So all of this is done by the pathologist, who will write a report. Now, most often a pathologist, once they identify cancer, now will order additional studies. So once we know that there is actual cancer in the tissue, that there are certain standard tests that have to be done. These tests are really important to guide therapy. So in a breast cancer, the typical tests that are done are stains for markers that include estrogen receptor, progesterone receptor, HER2, and other key markers. This is a very important step because the information from these markers actually guide therapy. So if your breast tumor is estrogen receptor positive, in all likelihood, that cancer will respond to anti-estrogen therapy. And there are several key therapies that an oncologist might prescribe to block estrogen signaling in those breast cancers. If the cancer has HER2 overexpression or amplification, that is also important, as there are targeted therapies that an oncologist will utilize to combat or treat a cancer that has HER2 overexpression, and these are extremely effective. Now, with the explosion of molecular analysis and targeted therapies, often a pathologist will also consider ordering a molecular analysis, and there are many different kinds of molecular analysis that can be done. A tissue might be sent for a single gene to be evaluated. For example, does a lung cancer have an EGFR mutation? This is really important to assign anti-EGFR therapy to that patient. That type of therapy is useful only in tumors that have that particular mutation. In fact, if you give it to a patient who has a tumor that does not have that, they will actually do worse. So it's very important that the correct tests be done and that the results are delivered to an oncologist in a way that they can understand. So single molecular tests can be done, or also a panel of molecular tests can be done. So there are panels that may have 5 genes or 50 genes. There are some panels that have over 500 genes. And when you use a very large panel, this is considered comprehensive genomic profile analysis. And this is where we get a very, very complete assessment of the molecular features of a tumor. So we will evaluate over 500 genes, look at the DNA mutations, look at the RNA mutations, and also measure important things. Are there actionable mutations? What does this mean? This means that there's a particular mutation that's matched to a therapy, and this is considered a companion diagnostic. So the EGFR is a good example of that. If there is an EGFR mutation, there will be a treatment with an anti-EGFR agent. There are other markers that can be present in the comprehensive molecular analysis. For example, a tumor mutational burden. If a tumor has a high tumor mutational burden, those tumors are actually generally treated with immune therapy. Likewise, if there is high microsatellite instability in a tumor, those tumors will also be eligible for therapy with an immune therapy agent. So this assessment with comprehensive genomic profile is extremely important. Now, it's normally indicated only in advanced tumors. Those are stage 3 and 4, where we're considering use of systemic therapy, like immune therapy or other types of advanced targeted therapy. In early stage tumors, it may not be as important, although it is now becoming clear that even in earlier stage tumors, that knowledge of the molecular phenotype can really help guide therapy for early stage tumors, and also to give us information that should that tumor come back over time in, say, 6 months or a year, we would now know what are the molecular features of that tumor and how they should be treated in the future. So all of these activities are coordinated by the pathologist, and you can see how important it is that a pathologist be up to date and aware of the correct testing and the correct classification of cancer. Now, what really complicates this is that tests change very quickly, so that even 3 or 4 years ago, there are many less tests available. Every year, there are new therapies that are approved by the FDA. In fact, last year, there were over 56 new therapies that were approved. Many of these therapies are linked to companion diagnostics, which means the therapy cannot be used unless the result of a specific test is available. A patient will not have that result available if the pathologist or the oncologist did not order the correct test. Now, pathologists are highly trained. They've gone through a training program, as I said. They're first and foremost physicians, so they've all gone to medical school, and then they've chosen to specialize in pathology. And typically, they will enter a 4 or 5 year residency where they will focus on the study of pathology under direction of a fully trained pathology expert, and often many different pathology experts. So during their training, they will learn how to evaluate tissue. They will learn how to grade tissue down the microscope and what tests to order and how to write reports. So generally, pathologists are extremely well trained, and they're very capable. However, one of the challenges in cancer pathology is the field is changing so very quickly. This basically is a high-level overview of what happens to your specimen. I hope you found it informative. I think that to review, the main features that happen are, first of all, a diagnosis of cancer is often initially made by a patient finding a lump, or by radiographic examination or colonoscopy, finding an abnormality. The key step is the biopsy. The biopsy goes to a pathology lab, and a pathologist examines it and orders specialized tests. In most cases, this is done accurately and completely, but actually in a large number of cases, there may be gaps or errors in this process. Hence, I think it's very important for a patient to be aware of the vital role that a pathologist plays in the diagnosis of cancer. We often say that a patient doesn't have cancer until a pathologist declares that there is actually cancer present in a patient. And in fact, this is often really the gold standard, that an oncologist will not initiate treatment until a true tissue biopsy has been done and a pathologist has confirmed that there is actual cancer there. The other thing that's important for a patient to know is that it's easy to get a second opinion in pathology, because the slides can be shared. They can be shipped, they can be digitized and shared electronically with other pathologists. The other thing a patient should know is that paraffin-embedded blocks can be retrieved, so that even if you had your cancer diagnosis 5 or 10 years ago, you could have that paraffin-embedded block retrieved and reevaluated so that new tests could be done on it to determine if there are new treatment options available. This is important to know as our knowledge of cancer changes almost on a weekly basis. So a patient should have some satisfaction in knowing that their tissue is likely in some pathology lab somewhere and that they could retrieve it and have further analysis performed on it. Of course, the caveat there is that if a long period of time has gone by, the tissue may no longer be valuable and that a new biopsy might be necessary. If a new biopsy cannot be easily done, then perhaps a liquid biopsy is indicated, and this is where a blood test can be done to really give information about the current status of a tumor. And the liquid biopsy is a topic for another day. So for today, this concludes the episode of The Cancer Informant. I hope you found the description of the role of a pathologist and the tissue journey of a tissue specimen to be useful and informative. We look forward to receiving your feedback, and if you have any questions about this, or if there are any other aspects of this you would like us to discuss in the future, that would be more than welcomed. So thank you again for tuning into The Cancer Informant, and we look forward to you joining us in future episodes. Have a wonderful day.